Hello, good evening. So we are at the end of our journey for the first day, and we have seen very great lectures. At the end, I'll just go through the resistant hypertension. There are two subset of patients, or we see usually in OPD that one patient came with an accelerated hypertension, which is on our regular follow-up. Patient is already on multiple medications, but still patient is not having good control of hypertension. We do two things. Either we say that it is more of an white coat hypertension. Every time patient comes to our hospital because of white coat effect, patient is having hypertension, and will not treat that patient. And at the end of 3 to 6 months, we see the same patient at our emergency as an heart failure with preserved ejection fraction. So it is more often going for patient because of not treating properly hypertension, resistant hypertension, going for heart failure with preserved ejection fraction at the end of 6 months. And other subset is the same patients, because of white coat effect is there, we are increasing the dose of hypertension at every time which is patient is coming to our follow-up, and every time we are increasing the dose of our antihypertensive medications. And after 2 or 3 days, patient come to our hospital at the emergency department with the syncope. So two things are there. Either we are under-treating the patient, or we are over-treating the patients. In these two things, only one thing is missing, that we are not educating the patient and we are not taking the good help of, which is presently very nicely available, which is an ambulatory blood pressure monitoring device. So at the end of this discussion, at least we'll have few newer molecules. So possibly in another 2 or 3 years down the line, we'll have few molecules which will be available to treat our resistant hypertension patients, as well as intervention therapy at the end of this session. So as we know that there is a very global prevalence of 5 to 10% global prevalence of resistant hypertension, as we see, which is more concentrated in our India because of high salt, which is more of a double, which is 10 to 12% of global Indian prevalence of resistant hypertension. As we know that because why it is happening more in India, it is mainly because of decrease in awareness and because of because of inertia to treat the patients for the hypertension, inadequate access as well as affordability to the healthcare system, and increased dietary sodium level. So as all the guidelines have already mentioned that it is hypertension which is not being controlled, but because not getting control less than 130 by 80 millimeters of mercury or 130 by 90 millimeters of mercury with more than 3 medications at the optimal dose with good medications, no white coat effect, and optimal dose has to be there, and one of them has to be more often diuretic therapy has to be there. If despite of these all medications and with good compliance, if you are not getting control of that hypertension, then yeah, definitely we stamp it as a resistant hypertension. Before stamping this as a resistant hypertension, as we have already mentioned that what is true and what is pseudo-resistant hypertension. So pseudo-resistant hypertension, there are contributing factors like improper BP measurements. If patient is very obese and we are using a small cuff, there will be a BP fluctuations, white coat hypertension, under treatment, taking the wrong medications or wrong doses, stiffening of the arteries, and not following the lifestyle advices. So patient is taking more salt diet, because of that patient is having resistant hypertension. So why we need to see the pathophysiology? We know that more often sodium intake, RAS activity, increased sympathetic nervous system activity, as well as endothelial dysfunction. Everything leads to, at the final stage, leads to stiffening of the vessel, as well as resistant hypertension. Salt and water retention leads to resistant hypertension. So what is an implication? This is a 2018 paper which has divided patient into with resistant hypertension, without resistant hypertension, which says more than 4 lakhs patients were included. So 32% patient with resistant hypertension, increased risk of end stage renal disease, goes for the CKD. 24% increases the risk of ischemic heart events, 14% increased risk of stroke, and 6% increased risk of death. So because of this morbidity as well as mortality, it is mandatory for us to diagnose the resistant hypertension and treat it properly. So as we know, this is very nice slide. So if there is a suspicion of resistant hypertension, there is first always exclude pseudo-resistant hypertension. If there is no pseudo-resistant hypertension, then you go for another step, which is in discontinuation or minimize the interfering substance. If patient is already taking NSAIDs, or if female patient is taking any oral contraceptive pills or hormonal therapy, you have to exclude that before stamping it as a resistant hypertension. If that is also not there, Then you go for the secondary screening or the secondary causes of hypertension in the form of primary hyperaldosteronism, CKD, pheochromocytoma, or mainly obesity as well as obstructive sleep apnea has to be ruled out. And if finally everything is ruled out and still patient is having persistent more than 130 by 90 millimeters of mercury blood pressure, then we stamp it as a resistant hypertension and we treat the resistant hypertension. So all the data says that every target has been given by the ACCH is also shown 130 by 80. If it is a patient is having associated comorbidities like diabetes as well as CKD, our target is less than 120 millimeters of mercury. So it's a multifactorial approach is there. First is in lifestyle modification, as we already says, as discontinuation as interfering substance. If patient is taking any medications, that has to be stopped. Rationalization of current treatment, and the sequential addition of antihypertensive drugs and existing triple therapy medications. So how we step up or how we approach for the medical therapy. So as we know that we start with the medications. If patient is not following lifestyle modification, we always tell to adhere more to the lifestyle modification. If patient is already on lifestyle modification, add on diuretic therapy. Maximal tolerated dose of diuretic therapy. If still BP is on higher side, go for an spironolactone. That too often start with the low dose. Go to the maximum tolerable dose without getting any hyperkalemia. If despite of adding spironolactone, if patient is having hypertension, you can add on to the central agents like alpha blockers or beta blockers if patient is having angina or heart failure. And if despite of this everything is not getting control, then you go for an newer medication as well as for the interventional therapy in the form of renal denervation. So these are few emerging drugs. These are still in under trial as well as clinical 3 or 4 trial is still on there. So as we have already discussed more for the kidney RAS system, this is a recent molecule or which will come in another 3 to 4 years, which is a firibastate. It is a brain aminopeptidase inhibitor which inhibits angiotensin 2 to converting into angiotensin 3. This is mainly for the RAS activity into the brain. So it has to cross the blood-brain barrier and it has to act on the brain. So if you stop this angiotensin 3, what it does? So angiotensin 3 is not binding to the angiotensin receptor. Because of that, there will be a decrease it reduces the vasopressin, increases the diuresis and decreases the extracellular volume. By that, it reduces the hypertension. It improves the baroreflex function. Because of that, it decreases the blood pressure and it decreases the sympathetic tone from the medulla. So because of that, there will be reduction in the hypertension. So human phase 1 and phase 2 clinical trials has already finished and which has shown a significant improvement in a hypertension in a resistant hypertensive patients. So in another future trial, we'll have firibastate for the resistant hypertension. Another very important is an endothelin 1 receptor antagonist. As we already have the macitentan, bosentan, everything is there. This is a similar class of the drug which is an aprocitentan. This is a similar, it's a dual pathway inhibitor, dual receptor inhibitor, ETA, endothelin receptor A as well as angiotensin receptor B blocker. By the end of this, because of producing more diuresis, it reduces the hypertension as well as endothelin because of reduces the vasospasm and fibrosis, it reduces the hypertension. So this is a precision trial. It has also shown a significant improvement in hypertension with the aprocitentan, which is similar to that of a macitentan. In a near future, we'll have aprocitentan in a market for the hypertension. This is another reason aldosterone synthetase inhibitor, which is an dextrostate, which is an end stage. Every pathway, if you see, consider at the end, it goes to the aldosterone, and this is the main factor for the resistant hypertension. If you stop the synthesis of aldosterone, there will be a reduction in the hypertension. There will be more diuresis and salt and water retention will be reduced, and hypertension will be reduced. This is the same Brighton trial is there, which has shown a significant improvement. Dextrostate have dose-related reduction in a blood pressure. As we already discussed, more of an inclisiran, this is more of an zilbesiran, which is an inhibitory RNA, which is an interface. By the RNA, we are reducing the liver production of angiotensinogen. At the end of when there is no angiotensinogen, there will not be any angiotensin 2 or angiotensin receptors. So there will be reduction in the hypertension. This is another trial which is an ARNI. Nowadays we are using an ARNI for the heart failure, but now because of Paramount trial which says that even if in resistant hypertension, we can use ARNI as an hypertensive medication with a preserved ejection fraction also. Not for the heart failure, but to treat the resistant hypertension, yes, we can use ARNI for the resistant hypertension. This is an orciduron, which is a non-steroidal mineralocorticoid receptor antagonist. This is a blockade CKD trial, which was used for in a CKD patients, which has significantly reduced the hypertension without producing an hyperkalemia. And as you know, there's nowadays it's an interventional therapy for resistant hypertension, which is a Medtronic Simplicity catheter is there, which is a spiral catheter for the renal denervation therapy. All the sympathetic activity and hypertension is mainly because of the renal artery sympathetic activity. So if you do the denervation of the renal artery by the Simplicity catheter, there will be a reduction in the hypertension. So this is a Simplicity 3 trial for the renal denervation therapy, which has shown a significant and sustained reduction. So even after the renal denervation, there was a sustained reduction in hypertension for a prolonged period. So renal denervation therapy also can be given for the resistant, very refractory and resistant hypertension patients. This is not very much used, just for the experimental purpose. This is a Barostim Neo, which is for the carotid stimulator, baroreflex activation. When you activate the baroreflex, there will be a reduction for the hypertension. That also can be used for the resistant hypertension. So at the summary, uncontrolled blood pressure more than 130/80 is considered to be as an antihypertensive drug. With persistent hypertension more than 130, we stamp it as an resistant hypertension. And novel agents like aldosterone synthase inhibitor, sodium glucose co-transporter also can be used, as well as renal denervation also can be used for the resistant hypertension. Thank you.
Thank you so much, Dr. Sanjiv. I would request chairpersons and experts, if any questions are there. Dr. Jay, would you like to ask something?
So one question to both of them. Bhupesh sir, if you want to give non-steroidal MRA, Finrenon, in diabetic kidney disease, in heart failure, which is recommended, but at the same time, if I wanted to use as a molecule which has already been stating, like we are using MRA for heart failure, do we, are we at the stage where we can completely recommend Finrenon for heart failure, be it diabetic or non-diabetic?
I think, see, Finrenon, basically HEPREF, HEP-MREF and HEPF, I think there is no clear-cut guidelines, but I think for the trial purposes, I think we have divided like the 40, 40 to 50, 50 to 60 or more than that. But I think majority of the trials, they are for HEPREF, but I think non-steroidal MRAs, mainly for the HEP-MREF and HEPF. So after diuretics and SGLT2 inhibitors, I think this is the one molecule. Of course, GLP-1 agonist which are there, but I think this is already proven therapy because of the fine heart failure therapy. But in future, I think another 4 trials which are going on with the Finrenon, maybe, I mean, Dr. Jay Gopal is may put some light on it in HEPREF patient also. Non-steroidal MRAs with SGLT2 inhibitors, I think it's also another good combination. But at present, it's still not recommended, but looking to the trial, I think we can push them in the HEP-MREF and HEPF, because still it is not included in the guideline. In future, it may come in the guidelines of the HEPF patient.
Yeah, I think the data from the financial is quite promising. But I think the only problem with the issue is that hard outcomes are not there in FF. So you are basically going to look at the quality of life, and then all of us know the HFF is actually a disease of various comorbidities. So how it will evolve over a period of time, but what is even more striking is probably the GLP agonist. So I think in the context of the newer drugs come in, I don't know, it is too premature to jump into the conclusion that Finrenon will totally replace. And again, if you look at the TopCat trial also, aldactone in the spironolactone, it did very well in the in the American population, but not in the used European. So again, there's again questions raised about the whether they were truly heart failure patients. I believe that there's a big thing coming up saying there's an industry bias also in this Finderon trial. So I think too early days. We still have to wait for much larger data before we think that we will replace all the MRI with Finderon.
Suppose this hyperkalemia with spironol electron, if we want to restart, probably we can think of Finerenone. I don't know still because hyperkalemia is little
Statistically less hyperkalemia.
less hyperkalemia.
But
So
I think the current thinking is, you treat hyperkalemia with other agents.
other
So again,
agents.
there is
It's not
a
maybe.
bias there.
And Dr. Sanjiv,
My question to Dr. Sanjiv, you haven't touched refractory hypertension and how you will treat, and to all the eminent cardiologists, what is the prevalence of this refractory hypertension in our population?
So first is a refractory hypertension is more of a subset of itself. It's an for of a resistant hypertension. But for the resistant hypertension, we have the identifiable causes are there for the resistant hypertension. So resistant hypertension will more prevalent for the females. Resistant hypertension will have more of an obstructive sleep apnea will be there for the resistant hypertension. So if you treat more of an causes for the resistant hypertension, causes like obstructive sleep apnea, or patient is already on any non-steroidal anti-inflammatory medications or anything, if you treat that cause, then patients will be having better control of the hypertension. But without any cause, patient doesn't have any obstructive sleep apnea, patient doesn't have any drug medication history also, and because of its inherent sympathetic nervous system overactivity, despite of multiple medication, patient is not getting treated with good control of the hypertension, then we stamp it as a refractory hypertension. And definitely refractory hypertension, at the end they need with the multiple treatment. If it is not getting controlled, definitely intervention is needed in the form of renal denervation therapy.
so what Sanjiv has told as an extension to renal denervation, three important things which we need to remember for RDN, that is renal denervation therapy. One, that if I use only RDN without any antihypertensive drugs, then what will be the reduction of blood pressure after that procedure? That reduction is in the range of 19 millimeter of mercury. That is in Simplicity 3 track. That is number one. Number two, if I use 3 antihypertensive, which is the actual treatment for resistant hypertension, and if patient is convinced for RDN therapy, then the reduction would be in the range of 34 to 35 millimeter of mercury. The two drawbacks of RDN, one is the cost, around 8 lakhs for that therapy, device therapy. Second drawbacks, it does not produce any major, I would say, it's not recommended even for ESRD or a kidney compromised patient. The main area of concern of resistant hypertension is either CKD or stage 3 or 4 CKD, where hypertension is one of the major cause. And you are having a lot of patients, those who are having uncontrolled hypertension with CKD. But in that subset of patient, if the eGFR is less than 40, RDN has not shown any major reduction. So that is the main drawback. Otherwise, in a normal individual with a good eGFR, I think RDN is probably going to be the future device therapy for hypertension treatment.
Thank you.